Hi, good morning, everybody, and welcome to the STRIPE All Members meeting. Today's Monday, September the 12th. It's great to see new faces, and it's great to see all the returning faces. Hope everybody was able to have a wonderful summer and even maybe this past holiday weekend. And we're excited not only for our agenda that we have today, but for back in-person meetings. I know we've seen some of you already at some in-person meetings over the last few months, and we're excited for what seems to be even more meetings ahead this month, next month, and the coming months. And we're excited. It seems like there's somewhat of a semblance of things are not only going back to normal, but we're able to do even new things that we didn't think we previously could. So I'm excited again to welcome everybody to today's All Members meeting. We got a nice agenda today. I'm going to pass it over to Sarah, who's got some updates for you before we jump right in. So great to see everybody and looking forward to it.
Great. Well, thanks, Ben. And first, we wanted to announce that applications will open this week for the STRIPE Patient Advocacy Access and Equity Committee. The application period will be 60 days and will close on November 15th. So if you expressed interest in this committee when you registered for STRIPE, you will get an email inviting you to apply. If there's an organization or individual that you think would be a great addition to the community and to this committee, please encourage them to complete the application. You do not need to be a member to apply for this committee, but anyone who is appointed to the committee would need to complete the registration and sign-on process, as well as complete a conflicts of interest form in order to formally accept the appointment. To complete the form, applicants will review the proposed committee charge and answer a series of questions based on their perspectives and experiences to provide feedback on the charge and how to achieve the objectives of the committee. In particular, we're seeking to identify committee leadership. So typically this is a chair, a co-chair, and a vice chair. So anyone interested in learning more about serving in a leadership role would go ahead and indicate that on the form, and we would follow up directly with leadership candidates. Once appointed, the committee leadership would help refine the committee scope and objectives and advise on committee composition. So we really want to engage more closely with patient advocacy groups. So this is everyone's chance to reach out to those individuals and groups that we can bring into the STRIPE community to learn more about their challenges and work together towards developing shared solutions that lend to more equitable, accessible, and personalized care. So with that, I'll turn it over to our guest speakers, Adriana Malheiro and MedGen Kane. Adriana is a certified genetic counselor and serves as the director of the NIH Genetic Testing Registry and MedGen. She's also the editor-in-chief of the Medical Genetics Summaries. Adriana received her MS in genetics and human genetics through the genetic counseling track from Howard University, where she studied genetic markers that predispose obese children to diabetes, and received a dual BS degree in biology and clinical laboratory sciences from the State University of New York at Stony Brook. MedGen Kane earned her PhD in human genetics and molecular biology at the Johns Hopkins McKusick-Nathans Institute of Genetic Medicine, with a thesis on LMNA-related premature aging disorders. She completed postdoctoral training with the NIH Undiagnosed Diseases Program and the Inova Translational Medicine Institute. MedGen joined GTR at the National Library of Medicine in 2020 and is the lead author for the Medical Genetics Summaries and the Medical Genetics Curator for the MedGen and GTR databases. So welcome, Adriana and MedGen. Thank you for being here, and we look forward to hearing more about NCBI resources.
Hi, good morning, everyone. So I'm going to share my screen, so hopefully you can see our slides. Okay, can you see the slides okay? And can you hear
kind
me?
of a pop-up in the middle. Is that my screen? Oh, okay, sorry, that was clear for me. Screen.
Oh, okay. Well, if other people can see it, great. If not, then we do have a problem. Can you hear me though? Yeah, okay. So we're all set? Okay. So I'm going to be talking about GTR and then also touching base on the other NCBI resources that are MedGen and the summaries, just to let the group know what we're doing, and then I want to see how we can collaborate in the space of pharmacogenomics. So giving some introduction about GTR, it is a database of genetic tests, or it started as a database of genetic tests, and those could be biochemical, molecular, or cytogenetic. The unit in GTR really is an orderable test, and the test can be both clinical and research. And it is free to participate in, labs to share their test descriptions, and it is free to use because we are housed at NIH. The GTR website also has some supporting resources about the genetic phenotypes and genes, and we try to link to all of the information that is useful to clinicians from the website. And this is the URL to reach us. Okay, so a little bit more on the background. The scope of GTR started as human conditions with a genetic component, and then COVID-19 happened, and we actually started expanding our scope to include microbiology tests, and specifically molecular and serologic tests for pathogens. And like I was saying, so each record in GTR really is an orderable test. So the expectation is for the laboratory to register their test like they do in their test catalog. We are housed at NIH, which means that we are not a regulatory agency. So the participation is voluntary. And right now we do have laboratories from around the world. We have laboratories from about 50 countries in the world. We have over 74,000 tests right now that cover over 22,000 conditions and 18,000 genes. Of all of these, we have about 880 tests that are for the purpose of drug response. Okay, so the goal of GTR really is to advance public health and research into the genetic basis of health and disease. It was established from recommendations from the SAGS, the Secretary Advisory Committee on Genetics, Health and Society, to really enhance transparency in the genetic testing field. And I cannot advance my slides. Okay. Okay, so it seems that my my computer froze for a second, so give me a second as I try to do this again. Let's see. Okay. Can you see the slide participating in GTR? I think
Yes.
there's something wrong with my slideshow. Okay. Hopefully I don't have to do this manually every time I need to pass this along. Okay, so to participate in GTR, for laboratories to register in GTR and then share their descriptions of their tests. So first, people have to create an NCBI account in order to access Submission Portal, and then provide information about the laboratory. Every laboratory entry is reviewed by GTR because, you know, we unfortunately get some submissions that are not from real laboratories, or are from laboratories that are just not in scope. Like I said, we are for genetic and microbiology tests. And then once it is reviewed, then we communicate with the submitters. We have, then the laboratory is approved, and they, the submitters can then share their data about their tests. So every laboratory will have an actual page in GTR that describes who they are, their licensures, and then all of the tests that they have. Okay, so then they can register their tests. I'm going to focus on clinical tests, but research tests can also be registered. We collect different types of information that we group in different tabs on the website. So we collect information on how can this test be ordered, like sample requirements, test codes, like CPT test codes, LOIN codes, and how to contact the lab. And then some, like what's the indication, what's the test purpose, what are the diseases covered, information about methodology and what the test interrogates, and what is the procedure for the test. We also collect information on performance characteristics. This is where the analytical validity comes in and assay limitations. Analytical validity was one of the big points that SAGS said was lacking in the genetic testing field, and that was the one of the fields that they wanted to make sure that a database like GTR would be able to collect. So this is one of those minimal fields that people have to provide. And then we collect information about sample reports. People can, the labs can share what's the policy to call a variant of VUS and things like that. And like I said before, we also share information about the laboratory itself. Now, the test information can be submitted either manually in the wizard, like one test at a time, or it can be submitted with an Excel file. So like a bulk submission, many tests at the same time. And once the spreadsheet actually is uploaded, validates, then the tests are registered automatically. And I do want to point out that we are working on an API-based submission, and this will be available soon. So for labs that have that kind of like IT support, an API-based submission hopefully will help like lower the resources needed to participate in GTR and then maintain the test information up to date. All right, so like I was saying before, so there's a information that we collect. There's some information that is minimal, like required in order to register the test, and then there's information that is optional, meaning that it's information that's important for maybe a clinician to see when they're ordering a test, but it wasn't deemed minimal, like required for submission. So I did put in the URL for our submission portal here, and then just to say that out of all of the information that GTR collects, what some of what we really need to know is the test name, the purpose of the test. Every test needs to have at least one condition and at least one test target. And then we also need to know about methodology and, like I was saying before, analytical validity. And then we have we give people the opportunity to share more information about their tests. So they can share, for example, CPT codes, clinical utility, how to order a test. Is the test, for example, FDA reviewed? Does it have New York lab approval? So people can give us all of that information if they want to, and hopefully they do. And the way that we incentivize people to expand on their test descriptions is to then use that information when a user on the public site is searching for tests. On the left-hand side, there's the links for all of our health documentation about what GTR is and what a test is in GTR and how to register, and some health documentation to describe all of the fields that we collect. All right, so specifically for pharmacogenomics, people can use, so we have different types of test purposes like diagnosis, and one of them is the drug response, which is typically what is used for PGx testing. And then we collect, like I said, at least one phenotype. So we offer the opportunity, like we have a database of diseases, but we offer the opportunity for a submitter to give us a disease that we just don't know about. And I'm saying disease, but it could be any kind of phenotype. So for pharmacogenomics, it really is the drug responses. So we typically try to standardize our phenotypes. And one way to do this is to use for drug responses, literally the drug name, the generic drug name, and then response right after. So this is how we are encouraging people to describe their phenotypes when it's for a pharmacogenetics test. So right now, GTR has about 1,000 drug response phenotypes in our database, and I will talk a little bit about MedGen, but MedGen is our portal and database for genetic conditions. And we collect information from, for example, for drugs and how to create these drug response terms. We bring in from sources, from authoritative sources like PharmGKB and RxNorm. And like I said, we do then allow our submitters to GTR to add some disease, like some new names. So for the test targets, it is any gene associated with for example, the abnormal response to medication. So we do try to limit the gene entries to, it has to be the preferred gene symbol and the genes that are on the NCBI gene database, which is the most comprehensive database that we have access to. So, and hopefully it covers everything. So this is how we try to validate and standardize the genes that people use to describe their tests. So like both the genes and the diseases, we're trying to standardize the entry of data so that then however people are using the search site, the standardization hopefully helps that end as well, them finding the tests that are needed. Okay, so then we do collect information, like I was saying, about methodology. People can enter the specific variants that they look for in their tests. So they could enter the alleles, the haplotypes, and then they can also tell us how they report the information for pharmacogenetics. So they could, for example, upload a sample report for their pharmacogenetic tests. And then I just want to point out, like I was saying, like GTR does have these like supporting information kind of pages. So we have pages that are dedicated for phenotypes, for diseases, and they have a description of the phenotype, and that can come from internally from medical genetics summaries, or they can also come from PharmGKB, Medline Plus, OMEM, any resource that might have a description about a drug response. We try to show it on this page. And then we also on this page, once someone is learning about the drug and the drug response, then they can see what are the available tests in GTR, what are the genes that are involved. And then we also display therapeutic recommendations. We display them from medical genetic summaries, but medical genetic summaries, it's an internal project that really brings these recommendations from authoritative sources like medical societies, CPIC, and other professional societies. We don't actually create these recommendations ourselves. We just aggregate them and then display for everyone to see. And then on the right-hand side of every page, we try to link to other resources that clinicians might need to learn more about the test, more about the gene, the disease. So we do provide links on the right-hand side. So like I was saying, I did want to touch base just to let you all know that we do have other resources, one of them being MedGen. And MedGen is, again, an online resource for human diseases and phenotypes with a genetic component. So we try to say like it's a one-stop shop. We aggregate information from all available resources. We put them all in one site. So you have access to OMEM, HBO, gene reviews, like everything that has information about clinical genetics. We try to put it all in one page to make it easier for someone to find information about their genetic phenotype. And we also have a list of professional guidelines, again, that we aggregate from their authoritative sources. And then the other resource that I did want to point out is the medical genetics summaries that we are creating, that we have in-house. So this is a book, an online book. So it's basically each chapter synthesizes the pharmacogenetic evidence and provides practical information about genetic testing to guide therapy on a particular drug. So each chapter is really dedicated to one drug and then whatever genes that influence the drug metabolism. So we do this online. It's extensively reviewed by external reviewers. And this is also where we aggregate all of the therapeutic recommendations that we then display in MedGen, and we display in GTR. We display them everywhere. All right, so now I really like the meat of this talk really is to bring up the potential collaborations between our two groups. So we do want to see how we can help, really promote the standards in pharmacogenetic testing in this kind of field. So some of the things that that we can talk about is, for example, I was saying that GTR has documentation about how to register the test, what the fields on a test are supposed to be collecting, and we do have some validation in place to make sure that the information that we get is valid. And one of the things that we could potentially do is add to our existing documentation some links to, for example, if STRIPE has guidelines or standards, or if you know of best practices, or how you envision test descriptions for pharmacogenomics to to be most relevant. We can provide that kind of information to people who are submitting their test information, their description of their tests, but we also can make that information available to people who are looking for pharmacogenetic tests. And then if there are any ways to standardize, like test descriptions, I just want to point out, for example, that United Healthcare does use GTR during their billing and reimbursement process to look at the description of the test and make their decisions. And then I just want to say that all of our data, so GTR does it, so all of our data is public and available from our FTP site, and I provided the link here. There's different reports up there, but if it would be useful for you to get reports of us in a certain way, we would be able and willing to provide any kind of information or data that's useful to you. We would be willing to discuss it. And so I just really want to open up the discussion on what can GTR MedGen and the medical genetic summaries, but in particular GTR, how can we really help STRIPE and your efforts to promote these standards and the uptake of pharmacogenomics altogether. So I want to thank you, and I do have the whole team. All of this is a lot of work, so there's a lot of people working on all of these resources, and the team at NCBI is all here. And if there's any questions, I'm happy to answer. And if there are any ideas on how we can help STRIPE, then I am willing to answer those as well.
Adriana, terrific. Thank you very much for that presentation. We do have some time for Q&A, so we'll just open it up to the members, and feel free to share your question.
George has his hand raised. If you want to go ahead, Dr. Petrinos.
Yeah, hi. It's good to see you all. Great presentation, Adrienne. It's very comprehensive, and I was particularly intrigued with the medical genetic summaries for pharmacogenomics. So myself, I'm chief editor of the Pharmacogenomics Journal. It's a journal on pharmacogenomics that's published by Nature. So I was basically wondering, and that's something along the lines of STRIPE initiatives, to compile consensus reports on existing guidance. Because as we have demonstrated, there is a huge variability between the guidance produced by the regulatory bodies and those produced by organizations like CIPIC and PharmGKB and the Dutch Pharmacogenomics Working Party. So I was wondering whether it would be something that would interest you to publish those summaries only for pharmacogenomics in the Pharmacogenomics Journal, that would increase the visibility and potentially its applicability among the healthcare professionals.
That would be great. I mean, like I was saying, all we do really is, public, and we do want to make sure that our work is shared everywhere. So I just want to point out a couple of things. So I'm gonna, if you guys don't mind, I'm gonna share my screen again just to point out the actual summaries. So this is what a page in the summaries, what it would look like. So we do have all of the summaries are standardized, and like what you are saying is exactly correct. So we bring in all the therapeutic recommendations from, you know, the FDA, because we are the government. So we do definitely have to pull in from the drug label and whatever the FDA says. And a lot of our, this page might have, you know, discrepancies in the sense of like the FDA doesn't always agree with the medical societies, doesn't always agree with CPIC, and you know, in the Dutch group, who we do work with quite closely, and they have translated some of their recommendations to English for us, because you know, we do need them in English. So we do have a relationship with them as well. So we do, like you're saying, so we do here do display all of the recommendations. We don't create recommendations ourselves. Like, we really do this for transparency. So a clinician knows, for example, that the FDA drug label might not agree completely with, like, you know, these professional societies where professionals are doing these evaluations separately. So it would be great to have these incorporated into your journal. I mean, all we do, like I said, is public, so so that would definitely be a great thing for us. So please do reach out to us.
Yeah, so and since you're a CPIC member, if you are a STRIPE member, and that's something that we were discussing to put under the umbrella of STRIPE, because it's an organization that also touches upon the FDA, since FDA is a member of STRIPE. Perhaps Ben and Sarah had something to hold a separate meeting to try to see how this could be formulated. So this would go out as early 2023, and this could go well in the future. As soon as we have some kind of new evidence, this could be added up into this particular listing of let's say recommendations. Would this make sense, Ben and Sarah?
Yeah, sure. That sounds great, George. If you want to put a few bullet points of what you have in mind and how you envision it and send it to us, we can bring it up at some of our upcoming meetings and kind of put together some additional ideas and feedback, but that sounds great.
Sure.
Let's take a couple more questions. I see Josiah, you have your hand raised.
Yeah, hey guys. Adriana, thanks for a great presentation. You know, in reference to your question of how GTR and STRIPE could potentially collaborate in the future, you know, one of the things that's a challenge from the provider perspective is looking at a lab and figuring out, you know, what are the evidentiary standards that lab is using to like make the recommendations that they're making. You know, are they using CPIC? Are they using FDA? Are they using primary literature? If primary literature, what sort of primary literature are they using? Are they using in vivo studies, in vitro studies? You know, sort of what's going into the recommendations that they're making on their test reports. Oftentimes, it can be challenging to figure that out. I know that GTR is voluntary, and so the information is coming from the labs themselves, and so there's going to be some degree of bias, or the lab gets to kind of say what is going on to their test versus not. And I think potentially in the future, you know, something that we've discussed at other times in STRIPE meetings is some sort of stamp of approval to sort of say, yes, you know, this lab has gone through some STRIPE approved process where we've evaluated their evidentiary standards and sort of signed off on them. So some sort of standard like that could be displayed on the GTR registry, were that to eventually be developed by STRIPE, I think would be a huge advantage for providers.
So a couple of things on that. One of them, you have my full support, so hopefully you do get to that level of coming up with those standards, and then we can display them for both sides, right? I mean, for the submitters and the users. But some of the things that I want to say is like we do collect information, but it's optional, like you're saying, right? Like we are not forcing people to give us, for example, the evidence of why they make certain interpretations. We just have fields where people can describe how they, like how they're making their calls. People as in the labs describe how they're making their calls. We do have some labs that provide citations like CPIC, for the calls they make. So we know at least like for those labs that they for example, use CPIC or ACMG or something else that people can share with then the providers. Because it's optional, it's not every lab that provides that information. So you're right on the ball on that one. But if we make, if STRIPE is to make those recommendations and we say like, okay, like STRIPE, if you're entering a pharmacogenetics test, like, STRIPE recommends that you provide this information. I do think that people will pay attention to that call, to that recommendation, if the recommendation is there. The other thing I want to say, actually, a few years ago, we tried to do something like what you're describing for maybe STRIPE to do, which is for organizations like ASHG or ACMG to come to GTR and they could look at the test and evaluate the test, and then we could put some kind of, I guess, a stamp of approval, just to say like, this professional society reviewed this test and, like it follows the standards and like, you kind of get that stamp of approval. We would be willing to, like the other societies didn't take us up on that offer because it was a bit of work, I guess. But if you were willing to do that, we would be willing on our side to display your review status, so to speak, on the website, so the users could see it, and then we can, like see how to make that, evident for the users to see, like, okay, STRIPE did look at this test and it passed the evaluation.
Great, yeah, that's fantastic. I think we have time for one more question, Dan, if you want to go ahead.
Yeah, hi. So in the area that I work in, which is DPYD testing prior to chemotherapy treatment, a lot of the providers ask about cost and turnaround time. I know cost is really complex because there are contracts and there's reimbursement, all those things. And you mentioned that you're trying to do some things in that space, and I'm not smart enough to figure that out. But the turnaround time piece, it seems like you could collect information. Do you have any information on median or like a maximum turnaround time from labs? Could they provide some kind of estimate, or could you collect actual data? Because that would be really helpful for our clinicians to know.
Oh, that is, I'm sorry, like that's one of those disappointing answers for you. It's going to be that GTR is, so GTR has a lot of stakeholders. We have working groups that tell us what we can and cannot do. And twice now since GTR started in 2012, we were shut down on both being able to collect or display both those fields, the price and turnaround time. The stakeholder groups that are from everything from industry, genetic counselors, like just different groups are represented in these stakeholders, and the majority of the members really are not, were not really keen on being able to share as a laboratory. And then they didn't see it as valuable enough information to be displayed. So we were shut down on that request to make available those two. And one of them for the price is exactly what you're saying. It depends on the, the contractor that, contract that you in your hospital or clinic have. And there was a lot of pushback because, list price is not exactly what the patient will pay depending on, the insurance they have and all of those things. But for turnaround time, I don't have a good answer for that one. But all I can say is that we're not collecting, so we cannot provide that information for you. On that note, anything else that we collect, we will be very happy to give you reports on.
I could make a comment about turnaround time too, that it's extremely variable. So, there are two very different topics. One is how long it takes to perform a test, which is very much dependent on the analytical method that's used. And the second is how long it takes to get a result reported, which not only involves that analytical component, but also the transportation and, you know, all the logistics. And that is extremely variable. So I don't think you're going to get any laboratories to provide turnaround time in any meaningful way, unless it's in a very local sense.
Thanks, Gwen. And with that, Adriana and your team, thank you very much again for your presentation and spending time with us this morning. We look forward to all the opportunities to collaborate with you, everyone at GTR. Next, I'd like to pass it over to Kristine Ashcraft and Whitney Zatzkin from Invitae, which have some legislative updates as well as some new insights on patient stories. So with that, I'll pass it over to them. Thank you very much.
Thanks, Ben.
I'll say hi while Kristine merges her slides.
Are you seeing the slides
Kristine?
now? Yeah. Okay.
Yep, sure are.
Just a few updates. I know we've had several conversations about the Right Drug Dose Now Act that was introduced by Eric Swalwell and Tom Emmer earlier this year. Just a reminder of what the legislation would do. Requires an assessment and update of the National Action Plan for Adverse Drug Event Prevention, creates educational campaign to prevent adverse drug events, including how to utilize pharmacogenomics, incentivizes updates to EHRs to ensure that healthcare providers are alerted to potential drug-gene interactions when making prescribing decisions, enhances the reporting systems that assist with tracking PGx-associated adverse drug events, such as updating FAERS, and authorizing sustained funding for PGx implementation, research, and guideline development. It was introduced back in February, and fourthcause.org and STRIPE have been working. Invitae has hosted a number of legislative meetings with the House and ENC committee members from a number of different states, Senate Help Committee members, and as well as additional offices. At this juncture, it is likely that this is going to be reintroduced in the next Congress, but really need your help in several areas to help move this forward. We do get a lot of interest, and people generally think this is useful, but I think most of the conversations have been educational in nature. A lot of people don't know much about pharmacogenomics. When they are informed, they're pretty supportive of doing what they can to move it forward. But I'll hand this over to Whitney to share a little bit more about how you can help move these efforts forward.
Great, thanks, Kristine. It's great to see some familiar names and faces today. I'm grateful to everybody that hopped on to join us. We do have a really urgent call to action around the RIGHT Act regarding your personal story, whether it's your story as a patient, your story as a clinician who had a major therapeutic breakthrough with a patient, the details and the nitty-gritty and the stuff that seems kind of unexciting but is actually really exciting. Those are the stories that help paint the picture and bring it into focus for our legislators. I'll share during one of the meetings a couple of weeks ago, Invitae presented a patient story that actually came from a member of our staff who it turned out to be the entire driving force behind his career at Invitae and in biotech. The added touch and deep intimacy that comes from an individual standing up to say, hey, I know it sounds like it's science and arduous and budget line items and accounting and all of these technical things, but at the end of the day, it saved my life, or it changed my future, or it made me more capable. It let me have a future. Those are things that legislators are frankly very thirsty for. It's something that they've been severed from for several years just because of COVID. It is something that completely changes the tone of a dialogue. And we've been asked by legislators who are sort of riding the fence right now to prove our worth. They're asking us to find the patient in their district or in their state who is willing to take the meeting and share their story. And so with Sarah's help, we made this beautiful map. If your state is in blue, we need to hear from you. I've added the website where you can complete a story form. I will drop into chat my personal cell phone number and email address. You are welcome to text or email me, and I will get 15 minutes of your time. If that means it's while you're commuting your kids somewhere or running on a treadmill, I just need to hear a couple of details from you. And I am creating slides that we'll be able to use on social media, one-pagers that are disease specific. And our hope is at some point we'll be able to go back to the Senate Help Committee and go back to Energy and Commerce in the House and be able to say, hey, these are a ton of patient advocates who have had their lives changed because of PGx. And we know the financial value to the system, and we know that we can change lives, and we know that we can make a difference. And we want you to have the chance to take the microphone on this and stand with us. So I will share my information. I love seeing all the chats coming up. So sorry, Kristine, people might be distracted while you update on the California bill, but we'd love your help. And with that, I'll turn it over to you for the update from California. Thanks all.
Yeah. We also had legislation introduced in California, Senate Bill 1191. This essentially aligns Medi-Cal coverage with the Medicare LCDs. So for either CPIC AB or FDA medications that are already prescribed and of concern or are being considered, it would enable pharmacogenetic testing coverage. It also clarifies that tests can be ordered by Medi-Cal clinicians, including pharmacists, ensures that panel testing are reimbursed based on one HCPCS or CPT code, and allows for flexibility in permissible sample collection. So you could mail a swab kit to a patient's home in a rural or underserved area, for example. It has made it through every single committee with unanimous approval. And Governor Newsom has the ability to either sign it or veto it before the end of this month. So made it all the way through the process. If it does get signed by the governor, it will likely go live either at the beginning of 2023 or about halfway through the year. And here's where we could use your help. Submit a signature letter to ledunit@gov.ca.gov with the subject line SP 1191 request for signature. If you're interested in reproducing these efforts in your state, please reach out. We're happy to share the process in California. It's not going to be identical in every state because every state is a unique little creature in the terms of the way they move state legislation forward. But I know with the RIGHT Act, there were a lot of questions about how to address reimbursement, which is clearly a barrier to access. And after discussing this with a number of people, the thought was this is a better battle fought at the state level. The other thing going on in that area is the American Cancer Society has pushed forward biomarker bills in a number of different states. The biomarker bills are more broad than just PGx, but do include PGx testing. Essentially states that biomarker testing must be covered for diagnosis, treatment, appropriate management, or ongoing monitoring of a disease or condition when the test is supported by medical and scientific evidence, including but not limited to FDA approved or cleared tests or indicated tests for an FDA approved drug, CMS national coverage or local coverage determinations, and nationally recognized clinical practice guidelines and consensus statements. This has already been enacted in a number of states and is introduced in several other states. The intent of the American Cancer Society is to continue rolling these out to additional states around the country. Generally, they introduce a template as broadly as possible. You can see in the notes here that some of those do get refined as they make it through the legislative process in the different states. But this can be very helpful to expanding reimbursement. This isn't just for a single insurer. The intent is to mandate coverage across all insurers in the state for this type of testing. You can connect with ACS CAN in your state to learn more about these opportunities, like attending a lobby day or testifying in a committee. And as Whitney so eloquently shared, patient stories really, really matter. This is something that they're looking for as well. So encourage you to do what you can to help move these legislative efforts forward. Unless there's any questions, I'll hand it back to Ben. Figure out how to stop share.
Kristine and Whitney, thank you so much. Any questions from the group? Okay, great. With that, we'd like to pass it over to Jay Patel and Gwen for some updates from our subcommittees. So we'll pass it over to Jay, who's head of the Study Design Task Force.
Thanks a lot, Ben. So I'll make this pretty brief, and I don't have any slides to share here, but just to remind all the members on the purpose of the Study Design Task Force, really our goal here is to provide some high-level recommendations, tools, and resources regarding study design methods to optimize the clinical utility of pharmacogenomic testing. And so really here we're looking at what are those level of evidence thresholds that are really needed to demonstrate clinical utility and or recommend pre-treatment pharmacogenetic testing. And so we've sort of devised 3 subcommittees that focus on 3 different aspects. We've got a clinical subcommittee, a sort of cost economics reimbursement subcommittee, and a regulatory subcommittee. And so our charges here, which we're currently working essentially on the first 2 charges, the first is to really collate current recommendations from clinical organizations, professional societies, from the payer organizations, the insurers, as well as regulatory organizations, so the FDA, to really understand, again, what are those level of evidence thresholds that are required to demonstrate clinical utility. And then the second part of that is to really try to develop some consensus on the type and strength of evidence that's required to demonstrate clinical utility or recommend pretreatment testing. The second half of that is then more focused on then making recommendations for study design considerations and sort of creating a toolbox for researchers to access these recommendations on the various study design parameters. And so some quick updates in terms of the clinical subcommittee, which is being led by Dan Hertz. We've got a number of clinical pharmacogenomic experts that have essentially generated a list of drug gene pairs with potential clinical utility. And they're currently reviewing a number of relevant professional society clinical practice guidelines to really document the recommendations for or against pre-treatment testing, as well as any statements regarding the rationale for that recommendation. So we plan to utilize that data to then survey some of the clinical practice guideline committees to really better understand their process for evaluating the pharmacogenomic data and, again, that evidence that's required to recommend testing. So then similarly in the cost reimbursement subcommittee, we're using the same list of drug gene pairs that's identified by the clinical subcommittee. And we have collated the top 8 or 9 payer policies that really cover most of the US lives and have begun extracting coverage determinations for each of the drug gene pairs that were again identified by the clinical subcommittee. And so then we're also documenting the evidence that's cited for each of those recommendations, the actual reference or referral to any particular guideline, again, regardless of whether or not it was to recommend for coverage or against coverage, as well as any particular rationale statements, summary statements as to, again, why they're actually covering a particular test. And then similar to the clinical subcommittee, so here we'll sort of survey some of the insurers and the payers and use that data that's been collected to essentially request clarity on that process that is focused on evaluating the pharmacogenomic test coverage, the evidence, with really a goal of increasing transparency, standardization of coverage, and again, what is that level of evidence that's required for coverage. And so then the last piece with the regulatory subcommittee, here we have the group essentially evaluating the FDA-approved drug labeling to determine which drug gene pairs have had changes to their strength of recommendations for testing or their recommendation for or against testing and the cited evidence for that change in recommendation. So Renda Teeple is leading this particular group, and here we're working with our FDA colleagues to really better understand, again, that evidence that's required for updates to the package insert or recommendations for testing in the drug label. So altogether, we hope to have several manuscripts, white papers that will come out that really outline several of these findings, and we'll eventually, again, plan to develop some study design recommendations to really demonstrate that clinical utility, which should ideally really meet those evidence thresholds that are set by the professional societies, the insurers, the payers, and the FDA. So that's really the long-term goal. And so we've made several progress now. I've had several meetings, typically on a monthly basis, and have begun drafting the first set of manuscripts. Dan, Renda, did I forget anything, or Sarah, Ben, anything you wanted to add?
Thought that was very comprehensive. No, Jake, that was great. Thank you.
Perfect. Any questions from the members?
This is Dawn Cardero. I'm new to the group. My colleague Jason Parent had represented our organization, which is Point 32 Health. We are the recently combined entity of Harvard Pilgrim Healthcare and Tufts Health Plan. I am a genetic counselor by training, so thrilled that you invited some GCs to the call today. Thank you. And I spent about 15 years on the molecular diagnostic side. I would be happy to help you with your second subcommittee and just helping you frame up the approach you take with payers, because I have that background in how they might be making decisions and how to make sure you get the information that you need by asking the questions in the way that resonates. And I don't mean that in a negative way. It's just if you know how the payer functions, you're more likely to ask a question that kind of clicks, and then you get what you need. So let me know.
Yeah, definitely. That'd be super helpful. I know that we did have a Point 32 representative that was supposed to attend maybe one of the last calls. So I'm not sure if that was your counterpart.
It was me. I was here.
Okay.
Yeah.
Okay. Perfect. So Don, I'll definitely reach out to you, and we'll make sure we get you included in this, because that would be fantastic.
Great.
Great. Thanks, Don. Thanks,
Yeah.
Jake. Let's pass it over to Michelle from Consensus Development.
Rather.
Sorry, what's that, Sarah?
Gwen. Sorry, Gwen. Gwen would be up next.
Yes. So, yeah, thanks, Ben. So I'm Gwen McMillin. I'm the chair of the Consensus Development Committee, and we have been working hard to understand how we can best contribute to the community. The committee was established primarily to design and architect methodologies for enhancing consensus-based recommendations. And so we felt that we really need to understand the landscape of consensus development approaches and perhaps propose pipelines for different perspectives or a different audience, different problems. Certainly designing clinical studies and establishing payer relationships are very different, just as an example. So we have been giving the members of our committee opportunity to present their approaches to consensus. We also then solicited a compilation of articles that we felt were key relative to different consensus methods. We had 2 members blindly basically review those methods. Sarah put together a nice jot form mechanism for us to collect the responses. So our overall goal is to write a white paper that includes a description of the various methods we're aware of. So things like Delphi, ballot, evidence-based, decision tree, and so forth. And present the strengths and limitations of those different approaches. And as I said, hopefully present some pipelines that the community could use to help establish consensus in their areas. While we wanted to focus on consensus just in pharmacogenetics, pharmacogenomics, we found that there's pretty limited resources there overall. And so we've reached out to other areas of pharmacy and medicine that we felt were relevant. So we have these articles compiled. They've all been read. We've got the jot form data available to the committee members, and we've recently drafted an outline for this white paper and made some assignments. So we're in the process right now of each subgroup putting together their approaches and drafts, and then we'll move forward with presenting the membership our paper. So I think Allison was on here. I'm not sure if Carrie was. Do either of you have anything to add? Okay, any questions for us?
We have about 5 minutes left, so we'll open it up for any questions to any of the presenters before we adjourn for the day.
Okay, well, great to see all of your faces again here. I know it's been a minute since we all last got together, and thanks again for participating in and being here in the Stripe Collaborative community. We're excited from everybody we heard from today. We're excited for the momentum we have coming into the fall and look forward to seeing all of you guys at an upcoming event in person and getting back out there. So with that, enjoy the rest of your week. Thank you very much for your time. We'll see you guys all later. Take care.